Okay, good morning, good afternoon, good evening. This is CPD webinar series, Global Medical Education. Welcome everyone. Today we have two excellent speakers. The first speaker is Dr. Zubair Tahir, who is a consultant pediatric neurosurgeon from London. And the second speaker we have is Dr. Varda Qureshi from UAE. So I'm very delighted to introduce our first speaker, Dr. Zubair Tahir, um, who's going to talk to us about protecting minds, treating epilepsy with surgery. Just a couple of announcements. The CPD certificates, as usual, we will share the link, the Dropbox link later on during the session. And you can click on that link and save the file to your for your portfolio. There are two presentations, 20 minutes each. And in the end, we have about 15 minutes or so for the Q&As. If you have any questions, you can drop the questions in the chat box, or you can raise your hands and ask the speakers. So we will take questions after the second talk. So I would like to invite Dr. Zubair Tahir, and over to you. Thank you.
Thank you very much, Naseem and Mansoor, for this opportunity. I really appreciate it. And thank you, Varda, for sharing this session with me. I hope I am audible and everyone can see my slide.
Yes, we can see you. Yeah.
Yes, we can see and hear you. Thank you.
Great. So, and on my title slide, you can see a painting from 15th century titled as Cure of Folly. And apparently someone is treating the mind here. And of course, we have come across a lot forward than what we are seeing on this painting. So the reason to choose this topic in a way is twofold for me. First is the burden of the disease. This is WHO. So there are more than 65 million people worldwide who suffer from epilepsy. And additionally, if we consider the risk of premature death, that is 3 times higher than for the general population. In England only, the cost of misdiagnosis of epilepsy is almost 221 million every year. And with COVID pandemic, we do see that a lot of patients with epilepsy, they are not referred timely. The second reason is my interest with this topic, and that takes me back to my training time when I was at ATU. And in 2012, we published our experience of establishing first comprehensive epilepsy center in Pakistan. So why to talk about surgery? During our assessment in Pakistan in 2012, there were, considering that the population of Pakistan at that time was 196 million, out of them, 30% will be refractory to medication, which makes roughly about 45 to 50,000 patients who are candidate for epilepsy surgery. So although anti-epileptic medication is considered as first-line treatment, not all patients will get seizure freedom, and 30 to 35% will become refractory to medication. And once they are, the chances of coming up with a magic drug to cure their epilepsy is essentially less than 5%. So clearly, the surgery carries better chances of giving them seizure freedom, and if that is not possible, a seizure reduction. Equally, it is cost effective if we compare with the financial cost for patients if they need to take anti-epileptic medications lifelong. And obviously, if you have removed the seizure onset zone, you definitely reduce the chances of recurrence. And coming to pediatric practice, in fact, if we look at children, of course, uncontrolled epilepsy causes a big impact on their developmental milestones and also their academic achievement. So what is the data to support the role of surgery? there are very few practices in neurosurgery where we can back that up with randomized controlled trials. And this is the first one published in 2001 in NAGM, talking about role of surgery in temporal lobe epilepsy. And if you look at your screen, this Kaplan-Meier curve clearly shows that the surgical group carries better chances of seizure freedom as compared to medicines alone. This evidence was replicated in 2017 when the group from India published another randomized controlled trial for surgery for drug-resistant epilepsy in children. And here we are not talking about just temporal lobe epilepsy, but in fact, children who suffer from all types of epilepsy. And the Kaplan-Meier curve is not very much different than what we saw in my previous slide. So how is pediatric epilepsy different? It is different because the causes are different to begin with. And then the assessment, the way the children present in terms of their semiology of the seizures, the way we investigate, and once we investigate, how to interpret them, and more importantly, how we treat them. Now, if we talk about what are the commonest causes of epilepsy in children, we see developmental lesions, which are extremely uncommon unless you miss them in childhood to see in adult population. And here I'm talking about cortical dysplasia, which is essentially a disorder of neuronal migration quite early on, leading to an area of abnormality in brain cortex. Then similarly, we have got examples of hematomas and heterotopias, which are more common in children. Although in adults, we see high-grade tumors sometimes presenting as epilepsy, in children, on contrary, we see more low-grade glioneuronal tumors like gangliogliomas or DNET and low-grade gliomas presenting as seizures. And then there are certain hereditary conditions with genetic predispositions like tuberous sclerosis, presenting with intracranial tubers, very difficult to treat epilepsy with very complex epilepsy networks. And sometimes these children can develop subependymal joint cell astrocytomas known as SIGA. Additionally, we also see hemispheric pathologies. Interestingly, these pathologies are very refractory to medication, but on the other side, surgery carries much better chance of seizure freedom. And here I'm talking about Rasmussen encephalitis, hemimegalencephaly, Sturge-Weber syndrome, and early insult either because of vascular injury or hypoglycemia leading to large hemispheric infarcts. Now, once the patient has been referred to us, what exactly is involved in surgical evaluation? In a way, it is not very different from any other disease. You basically collect clinical data and then support that with imaging and electrical data, specifically in epilepsy. And here I'm talking about EEG. And what we are trying to achieve is to identify an epileptogenic zone. So like any other condition, history and relevant examination is of paramount importance. And you further back that up with an imaging, video telemetry, developmental assessments, and sometimes if we are unable to identify a seizure onset zone, like there is no pathology on imaging, some of these patients need to undergo invasive monitoring, and I will come to that. But for the sake of establishing this service in developing countries, I think it is fair to say that you don't need all these high-tech investigation modalities. Majority of patients, you can pick up a lesion on 3T MR and back that up with your EEG data. Once we have identified children with epilepsy, then this data is discussed in an MDT fashion. And here we have support from psychologists, psychiatrists, neurophysiologists, radiologists, and neurologists. In fact, if I have to say, the surgeon is a small part of this team, and patient is and should be always in the center of our discussions. And once we have got that data, we'll look into that and try to determine where the seizures are arising from and how much area potentially can be resected safely. And that's what we call our surgical target. So coming to the treatment options, you can resect that area of an abnormality like lesionectomy. We can perform that in cortical dysplasias or low-grade tumors. A lobe can be removed like frontal lobectomy or temporal lobectomy, commonly done for mesial temporal sclerosis. Uh, if the epilepsy involves more than one lobe, then the morbidity is quite high. And here we discuss the possibility of disconnection procedures. And these include either you disconnect the frontal lobe. If the pathology is hemispheric, sometimes we have to do hemispherotomy, essentially meaning literally disconnecting the whole hemisphere from the other hemisphere. Um, as the name suggests, temporo-occipito-parietal disconnection is disconnecting these three lobes from the frontal lobe. This is motor sparing type of disconnection. Corpus callosum is the biggest commissural network in the brain, and you can divide that, a procedure known as corpus callosotomy, to achieve seizure freedom. Additionally, we have options of neurostimulation, and depending upon whether you are stimulating brain or vagus nerve, you can offer VNS, RNS, and deep brain stimulation, DBS. These are primarily palliative approaches rather than a curative intent here. And recently, last but not least, minimally invasive techniques like LIT, where we use laser interstitial thermal therapy and thermocoagulation, where heat can be used to destroy that area of abnormality, can be also used to treat epilepsy. What I will do, I will go through certain cases so that I can back this up with examples, clinical examples. So here we have got our first case, 11-year-old whose seizures were started at the age of 2. And here I want to emphasize, despite all the knowledge and understanding of epilepsy, still, even in developing countries, developed countries like England, we do see delayed referrals. Looking at the seizure semiology, there is a flavor of frontal lobe epilepsy, and patient has posturing of the right arm, which refers to possible left hemispheric involvement, and EEG confirmed that. Neuroradiologist in this audience has probably already picked up the pathology, but for rest of us, we can see an area of abnormality in the superior frontal lobe. And here you can see there is, if you compare it from contralateral hemisphere, you see loss of gray-white matter differentiation and also the thickness of the cortex. So this patient was offered lesionectomy. Here we can see on the top 3 pictures starting from right-hand side, we have got dura open, that's anterior, posterior, lateral, medial. You have got superior sagittal sinus in the midline. And if you look at the brain, it does appear abnormal on gross inspection. This gyrus is clearly abnormal as compared to the rest. So the first step is to demarcate your area of abnormality. We call it corticotomy. And once you have done that, you remove the whole thing as en bloc from pia to pia, respecting the surrounding brain. And on the base, you can see white matter. During surgery, once we have achieved the specimen on dissection, we can clearly see the loss of gray-white matter differentiation. These are the post-op MRI scans showing complete resection. Histopathology came back as cortical dysplasia type 2B. The child is now seizure-free for 5 years and is off medication. Next case is a 17 years old who presented with tonic-clonic seizures with auras, typically of temporal semiology, and the EEG confirmed that there is electrical abnormality our anterior temporal region. This is one of the commonest pathology which our adult colleagues see, but we also pick them in childhood as well. Essentially, in front of you is an MRI scan, which is showing evidence of MTS or mesial temporal sclerosis You can see the right hippocampus is small as compared to the left and is more bright. So this patient was offered anterolateral temporal lobectomy along with amygdalohippocampectomy. This is how we positioned our patient. So temporal lobectomy has got two parts. The first step is to remove the lateral part of the temporal lobe. We call it neocortical resection. And here you can see Sylvian fissure and the temporal lobe. You have got specimen of lateral temporal lobe. And the next step is to resect the mesial structure, namely amygdala, uncus, and hippocampus. This is a view after resection of amygdala and uncus. We can see third nerve across the pia, posterior cerebral artery, brainstem, all preserved. Here I am lifting the hippocampus up, exposing the hippocampal arcade, the blood supply of hippocampus, and then in a very careful fashion, we resect that. This is the final view after doing temporal lobectomy. You can see the edge of the tentorium and the pia overlying is preserved. You can see the vein of labae draining into the sinuses. Here are the specimen for our pathology colleagues, and i.e. hippocampus, amygdala, and uncus. And histopathology confirmed this to be a mesial temporal sclerosis. The child initially remained seizure-free for 6 months. At that stage, we repeat the EEG, which showed no ictal or interictal discharges, and they are no off medication. This is post-op MR. Moving on to our third case, here I'm discussing a 10 years old who was born in good condition, but sadly developed symptomatic hypoglycemia and very difficult to control epilepsy. And EEG pointed towards the left posterior quadrant. And on this MRI scan, you can clearly see the left hemisphere looks abnormal and small as compared to the right. And this is primarily involving occipital, temporal, and parietal lobes. And here it is a major undertaking if we decide to resect all these three lobes. Hence, we plan to do a disconnection operation rather than resection. This is left hemisphere exposed. The first step is to identify your motor cortex, and with the help of phase reversal and direct cortical mapping, here we have mapped the motor homunculus. This is the arm area. We have got face here and hand knob is there. And the resection, the corticotomy disconnection line starts behind your motor cortex, going all the way down towards the temporal lobe. And this is the final view. We have done the temporal lobectomy as a part of our disconnection. And you can see the posterior temporal lobe, occipital lobe, and parietal lobe has been disconnected from the frontal lobe. On this slide, you can see down the images taken after surgery. Here you can see the disconnection line in front of our area of abnormality. And if I have to trace it down, this is the disconnection line coming into the ventricle and then moving forward, joining the part where we did temporal lobectomy. So this child, after TOP, became seizure-free, and now they are off medication. Our next case is 8 months old, a small baby who was born with...
You have a couple of minutes.
Okay, thank you. Typical skin stigmata of Sturge-Weber, known as port wine stain. This is their MRI scan showing typical PL angioma. This is how we position the child, a large question mark incision, the brain. These are remarkable pictures showing evidence of Sturge-Weber. And here we are planning to do hemispherotomy, which is essentially disconnecting the whole hemisphere. And you can see we took some specimen from the temporal lobe for histopathology. These are the final outcome after hemispherotomy operation. Our next case is a case of LGS. You know that these children suffer from drop attacks, and here we are proposing corpus callosotomy. This is how we perform corpus callosotomy. On your screen, you can see after craniotomy, we have done frontal retraction, gently exposing the corpus callosum, starting your corpus callosotomy, and then moving anteriorly and posteriorly to the genu and the splenium of the corpus callosum. And here we have replaced the bone flap, secured with the mini plates and screws, and sutured everything back. This is the post-op MRI scan. There is an option of doing anterior two-third versus complete corpus callosotomy. And these are post-op DTI images showing evidence of complete corpus callosotomy. Children who suffer from drop attacks and LGS, another option, as I mentioned earlier, is neurostimulation. Here we are implanting VNS, and this involves neck dissection and the left pectoral dissection. Here we have opened the carotid sheath. What we can see is a carotid artery, and next to it is the vagus nerve. Then we wrap the electrodes around the vagus nerve. You have got internal jugular vein next to it. And here we are wrapping these electrodes. This is the final picture. Then we secured the lead, tunneled the lead, and attached it with the generator. This is a palliative treatment. 1/3 of our patients after VNS, they are able to achieve more than 50% seizure reduction. And recently we have got minimally invasive techniques. Here we are using a robotic arm to place depth electrodes for invasive monitoring. As I mentioned earlier, sometimes these children have got lesion negative MRI scan, and here you can see a patient's head fixed with Lexel frame, and this robotic arm helps us to place these depth electrodes, and then we record EEG for a few days in order to establish where the seizures are coming from. And one of these electrodes can be used for thermocoagulation, or if the area is bigger, we can take the children back to the theater for resection. These are a few papers published by our institute, and for sake of time, I will go to my take-home message. I hope after sharing these cases, I have managed to convince you that surgery is safe, effective, and the only treatment for drug-resistant epilepsy. And this should not be considered as treatment of last resort, especially in pediatric patients, and children should be referred early to a center with dedicated epilepsy team. Thank you very much for the opportunity and for your attention, and I would be happy to take questions at the end of session.
Thank you very much, Dr. Tahir. Excellent presentation, excellent cases, very good. We learned a lot from this. So questions, we have got a few questions for you. We'll take questions in the end. So next speaker is Dr. Varda Qureshi. Varda, you can go ahead.
So good evening, everyone. Thank you so much, Dr. Zubair. It's a pleasure to share the platform today with you. Before we start, so I just want to have a quick, I would say, hello with everyone, and just to find out, how is everyone?
Thank you for asking.
Yeah, doing okay.
Thank you. We're
Surviving.
okay. Exhausted. Exhausted.
Exactly. So that's why I thought of doing this discussion today. So, of course, you guys, my classmates,
we have
know
Dr.
me.
Faisal. Dr. Faisal is wearing a mask. It looks like he's worried about he might get even coronavirus on the screen.
Is it like, PPEs over the virtual meetings as well? So, overcautious.
Like clinic and patient also are coming. That's the reason.
That's absolutely fine. So what I'm going to do is,
Varda, can you share your screen? I've
yeah, that's
made you
what
a host. Varda, can you share your screen? Yeah.
Okay, so I can start sharing my screen now.
Okay,
There you go.
I will have to leave because I'm going to other place. Okay, I cannot.
No, Faisal, no, you can't.
Faisal, please. Faisal, are you okay, Faisal? Please
I'm
stay.
to go to hospital. I cannot attend because I have to walk to hospital now.
Okay. But you look so darn tired, actually. So I thought this will be something you should listen to. Maybe you can put the headphones and just listen.
Yeah, definitely.
Without the video.
Okay, I'll try to listen. Okay, I'll try to be in the meeting.
Okay. No pressure. Just feel just do whatever is comfortable for you.
Okay.
So, guys, burnout in healthcare providers, prevention and remedies. This is a very well-known topic in the academic researches. This is something not new, which I'm presenting, but what I thought, like, this is the right time to talk about it at this moment. So have you heard this word before, burnout? I'm not talking about anxiety. I'm not focusing on depression. I'm just asking about burnout. Have you heard this word before?
Yes, we have. Yeah.
and practically experiencing it right now a lot.
Yes, exactly. Yeah, I'm sure
Gone
all
are
my
the
colleagues.
residency days. Yeah, so gone are the residency days when we used to feel like, "Arey yaar, thak gaye, oh, bahut thak gaye." But the thing is, like, this is the real, I would say, like high intensity burnout that is happening, and burnout is always and always work related. So it has nothing to do with your personal life or something. No, this is something, a very special word used for the work life, or you can say your professional life. It can lead to anxiety and of course depressions, which is happening all over the world right now. But the thing is, what did COVID-19 did to us? I don't have to tell you that. You already know. What I'm going to share with you right now, that even before the pandemic, these are the stats that around 40% of the healthcare providers were already facing an extreme burnout, especially people from emergency medicine, primary care, and of course critical care. That is known areas for us like high intensity areas. And what happened right now with COVID-19, that this percentage is actually increasing to such an extent that every other research they do becomes kind of, you can say, old within a week or so. So this is kind of an ongoing research right now. Hopefully by the end of pandemic, we might have exact numbers for that. The most important point right now is burnout is not gonna go away, just like anxiety or depression. It needs to be identified. We have to go through that phase of acceptance that yes, we are facing it. Otherwise, it will just get worse and worse and worse over the period of time. But what can we do right now? That's the whole point of discussion today. As we know, COVID-19 brought these new stressors. Now, before I further dive into it, if possible, guys, do you have a piece of paper, pencil, pen around you? Or is there any way you can write? I'm just going to request you to write a few things right now.
Of course,
But
we can. Yeah.
yeah, thank you. Maybe on your phones, notes or something. Just, I'm not going to ask you to share those points with me. This is something for you. You can say that this is something kind of event session for all of you, because I completely feel what my fraternity is going through right now. So if you do have an access to a pen, pencil, and a piece of paper, I want you to at least pick 3 main stressors from the screen right now, or maybe something beyond that, which basically came into your life because of COVID-19. So any of these, and I'm not going to ask you to share it with me or with anybody, but I just want you to write it down for yourself. Let's go through this identification acceptance process while we are having this discussion. For me, the most important is vacation reduction. So the whole year I have been going through vacations because the management didn't wanted to give us leaves, but we were, kind of placing the leaves in the system, and we were working on those days. So I started calling it vacations. So this is what is something like a big blow to me.
Yeah.
So pick any of these 3 or maybe more, or maybe something else which is bothering you right now. These are current COVID-19 stressors. In addition to that, I want to discuss the sign and symptoms, because we know that how important the sign and symptoms are. So any of these things can be expressed in the comments, which I've put it on the right side of the slide. I'm so exhausted, I cannot concentrate. What did you say? Oh, I don't focus. I cannot focus. And as an outcome, of course, most of us are married, so you can see that some kind of friction goes at the home. You somehow end up, kind of taking it out on your partner. Lack of sleep. It's not that you don't have a bed to sleep or you don't have a quiet place to sleep. Yes, you do, but your mind is so exhausted that you cannot sleep. So if you are facing any of these symptoms on the right side, or maybe something more, I want you to write it down on that piece of paper. Either you are being very kya kare, ye chal hi raha hai na, what can we do? It's just happening around us. You're so depressed to accept the reality, or you're becoming so aggressive. When will this end? When will I get rid of these masks? When I'll get come out of these scrubs? So the most crucial thing of this, the most crucial sign and symptom, I would say, of this burnout is increased error rate. Increased error rate is something which is an unforgiven sin for physicians and nurses and healthcare, allied healthcare. So what are the typical signs and symptoms? yes, it has negative consequences, not only for our patients, in fact, to our fellow colleagues. Sometimes we end up just like being aggressive or shouting at each other and decrease productivity. Maybe I'm doing a 12-hour shift because my hospital is forcing me to do a 12-hour shift, but my stamina does not allow me to do that. And of course, the healthcare system was always under the burden. We already had the shortage of physicians, and now the burden is increasing. So the idea is, the overall, if I want to summarize it, actually, it's in a very simple statement that burnout can zap the joy out of our career and, of course, our life outside of the work as well. Is it happening to you guys? Now I need an answer. Yes or no? Is it snatching away all the joy from your life? The feeling of burnout? All right, I don't see anything on the chat. All right, so the idea is, even before the COVID-19, approximately 400 physicians were committing suicide every year because of burnout. And you can imagine the pressure right now, of course, you guys know more than me because you're on the front line right now. So now you have written those points and things on your paper. I want you to have a look at this picture. So if you see two dolphins jumping out of the water, that means you do not need the vacation. You do not need vacations at all. Do you see two dolphins coming out of the waters?
No, we see one dolphin and one cow.
So you need a vacation. If you see two dolphins, then you're absolutely fine. You don't have a burnout. But if you're seeing one cow, that means you have a burnout. Anybody else sees a cow, or all of you are seeing two dolphins there?
I can see a cow, definitely.
Oh, so you are having a
Now
burnout, man. You need a vacation.
I am really getting worried because I can clearly see a cow. Where is the second dolphin?
Same here. I can see a cow. I can't see a dolphin there.
So guys, no, actually the picture is like that, of course. I just wanted to give you a different flavor of presentation, so I thought of doing that.
So I'm back from other place, from hospital.
All right, that's okay, Faisal. Thank you so much. So a quick video I'm going to show you actually how, because we all believe that prevention is better than the cure. So how you can avoid the burnout and how you can go, keep on moving with these things. So there is something which I usually use for my corporate trainings and LinkedIn Learning platform. I'm sure all of you are aware of it. If not, you can explore it later. So I am just going to quickly show a video from there. And it's a 3-minute video, which basically talks about the prevention. And of course, I do have a slide about few more suggestions. Are you ready to watch this video?
Okay.
Hooray, yes.
All right, thank you. I like that, yes. Here we go. Just let me know if you can hear it clearly. No, there we go.
Sorry, there's no voice there. Could you adjust the volume maybe?
Guys, just let me play it again. I don't know what went wrong with it.
Thank you. We couldn't hear the sound.
Before when I tried it. Sorry for that, guys. Technology issue. I don't know, something went wrong with this sharing thing, because before sharing it was playing very well. Is there any way that I can fix it? Trying.
Maybe you can share what are the key points from this video. What are the key messages?
All right. Okay. Yes. So basically, it starts with, of course, the healthy diet and the whole idea. As you can see the captions on the screen, actually. And the basic thing is like, you have to at one point disconnect yourself from the work. You have to not only 20 miles, but yes, you have to completely turn it off, which is sometimes not easy or not possible. In addition to that, the most important thing here is find a support group, which I believe we are a support group here right now. Maybe we can have one of the sessions where we can just like sit down and talk about the challenges that we are having. Of course, different specialities are going through different challenges, but there's no doubt that critical care and emergency medicine is under a completely turmoil, a different turmoil. So we can talk about it. And of course, practice positive thinking. The simple way I find this to do this is like if you have any kind of garden or any flowers around you, or maybe having small plants at home that makes you happy. Other ways, whatever makes you happy or makes you positive. So we can go and consider, of course, those things. In addition to that, check your goals again. Check your goals. Maybe we were planning to do some kind of things or achievements within like 6 months of 2020, but now things have been prolonged. So maybe it's time to erase and redo our planning. So let me take you back to my slides. I hope you can see my slides now. There we go. So on these slides, I do have some points as well. You can see the first and the most important thing related to the work, find your energy guzzlers and sources. So there are things which kind of drains you at work. Maybe it could be one of the colleagues or maybe some kind of process or system in your workplace. Try to distance yourself from that because it's going to suck all the energy out of you. And of course, your energy sources. There are things which makes us happy at work. So why wouldn't we invest our energy towards that? Secondly, and the most important thing, know your limits. We are forced to work 12 hours. We are forced to work 10 hours, but maybe your stamina does not allow that. Or maybe you need more gaps during the shifts or work, which I can understand very well that it's not easy these days, but still. Control the things which you can. There are a few things which are beyond our control. Of course, the pandemic and the flow of patients and increasing number of cases and the variants of the viruses. Of course, that is beyond our control. So of course, don't focus on those things. Just focus on things which you can actually control. And the last thing would be do something, some new 5 things which you haven't done in a while. Let's say in past 4 to 6 months. Have you read a new book? Have you called your friends? Or maybe you want to go and talk to one of the relatives? That would be something which will really, really help you to, can say bounce back. I was thinking to add resilience and change agility here right now, but once again, that will cause a lot of extension of the topic. Maybe later on, we can have another session where we can talk about building resilience according to this current situation, and of course how we can focus on change agility, because healthcare is going through a complete paradigm shift right now, and there are lots of demands on our end. It's no more the clinical knowledge that you need to carry. You need to adjust a lot with the new technologies, learn them fast so you can decrease the error rate, increase the patient satisfaction. There's a lot that is going on. Well, I would say one of the most hardly hit industry of Industry 4.0 in terms of technology. So maybe later we can talk about in another session for resilience and build and change agility. So last thing, guys, I told you to write few things on your paper and look at it, that how can you come out of those things. There's something which I regret very well these days, but I cannot travel. But at the same time, I decided to make short trips in the car, maybe within UAE, somewhere here and there. So all the points that you have written, identify those stressors, identify those feelings, and focus on your mental health at this point to decide how can you come out of it. Can you do it by yourself? Do you need a support group? Or maybe you need some professional help, support. Why not? Thank you so much. That's it from my side. So we can go to the questions.
Thank you very much, Varda.
Pleasure.
Excellent.
Thank you, Varda. Thank you.
Thank you. Excellent talk. So we have got some really, really good questions this time, Mansoor, isn't it?
It is. Shall we get Zubair as well, please? Is he around? Yes, because lots of questions. So shall we just start the Q&A? Naseem, do you want to lead on that? Yeah.
Yeah. Okay. So we have got some really good questions, and I think I would start with Dr. Zubair. So we have a question here. The so the question is that the issue with so this is the question. The issue with surgeons is that they take ECs and then show good results, but they need to consider the total patients with epilepsy and maybe let us know how many did they cure. So out of the total epilepsy patients with drug resistant ones, how many were able to cure surgery? Dr. Zubair, do you have any data, or is it only the ones that you have treated that are cured that we are taking into consideration? I hope
Thank you, Naseem.
I have made a question.
That is a great question. And first of all, I would like to congratulate Varda, an excellent presentation. Definitely, I learned a lot and I appreciate. So going back to easy question, easy patients and easy cases. mm, I think these are very challenging operations, and one has to be very clear about realistic expectations for, and when we consult that and we consent our patients and their families. In terms of data, I think it is very readily available on PubMed. There are a lot of publications now. Epilepsy surgery is an established treatment in drug-resistant epilepsy. When we talk about temporal lobe, not all patients are seizure free. The seizure freedom rate is 60 to 70%. So still 30 patients out of 100, they will not be seizure free, although you can offer additional 10 to 15% seizure reduction. The success is more in children who suffer from hemispheric pathologies and who underwent disconnection syndromes. And clearly on the other end of spectrum, we have got palliative treatment. And I did mention that in my presentation, like vagus nerve stimulation, where only 8% children, they get seizure freedom. And majority of them, they get seizure reduction rather than seizure freedom. And same is true for corpus callosotome. Corpus callosotome is good for drop attacks, but remaining seizure profile will continue. So yeah, there is a lot of data, and I'm sure it will help while we counsel these patients.
So just to clarify, Dr. Zubair, it is 60 to 70% of drug resistant patients that are undergoing surgery are successful. So 50% is still having seizures, is it?
That is correct. So if we look at all the patients who suffer from epilepsy, 30 to 35% will become drug resistant. And the definition of a refractory epilepsy is a patient who has tried 2 anti-epileptic medication and they are still not seizure free. And in those patients, and that is a large number of patients considering how many, how prevalent epilepsy, it is considered as among 10 chronic non-communicable diseases like stroke and like diabetes and like cancer. And still there a lot of patients undergo these procedures. And depending upon your cause of epilepsy, as I mentioned, cortical dysplasias and low-grade tumors, the success rate is close to 80 and 85%. In fact, we published 2 years back, I can share our paper of children who undergo surgery for glioneuronal tumors. 85% of them were seizure-free after surgery. But children with atonic drops who undergo corpus callosotome and VNS, the success rate is definitely low.
Thank you.
Naseem, did you read the first question? No, sorry, Naseem, did you read the first question for Zubair Bhai? It was actually 30% non-medication response does not seem likely, as we did not see so many, that is 1/3 epileptics being offered surgery in the UK.
Again, a great question. I'm glad this question was raised in this session. This highlights the need of public awareness and awareness among GPs and neurologists that there is a treatment option available. There are a lot of epidemiological data there which definitely shows that 30 to 30% patients overall, they will not respond to these medications and they are good candidates for surgery.
Thank you.
Thank you for that.
For you, you mentioned about physicians' burnout rate. Does that include, when you say physicians, mean just like not surgical specialty, or
No, no, actually, you know that like when the academics, they do the research, when they say physicians, that means the whole, medicine. It could be someone from general surgery. It could be someone like a neurosurgeon. It could be an ER physician. It could be any specialty. It's a very general term which academics use for for doctors.
Okay.
So yeah.
Okay.
So I like it.
Question
It's
we
quite
have.
interesting.
Yeah, sure. So the other question is, you mentioned about ITU and emergency medicine stress area. So Dr. Imran Aziz is asking, the ITU is taking 10% of patients, and respiratory physicians are taking 2 to 7%, acute medicine, and some other acute specialties. So is the stress rate and burnout rate, have you looked at in other discipline, specialty areas, or?
All right. So let me repeat actually what I said, that even before pandemic, it was documented that 40% of the, you can say healthcare providers from these high intensity area were already facing the burnout, especially like in Australia and UK. There have been a lot of researches that have been done for this physician burnout, as well as, healthcare providers burnout. But specifically, yes, they are doing more researches these days, but everything is becoming irrelevant within a period, or you can say within a span of 1 month. So maybe by the end of this pandemic, whenever we will reach that, we might have very realistic data to talk about it. But right now, yes, they are doing these researches. The data is being collected.
Werda, can I just actually ask a question, just taking the lead from the previous question? Now, burnout is a very sort of familiar and recognized terminology in the West, I would say in the UK, US, Australia, New Zealand, as you said. What's kind of actually, or what's the prevalence, or what sort of burnout strategy or prevention is seen in countries like the Middle East or India's subcontinent, basically? Is there a concept about burnout in those countries? And then could you shed some light? I know you did mention about your experience in the UAE, but what about your colleagues who have actually been working non-stop? And we've got Faisal here as well, who could share his experience in Bahrain. So sorry, lots of things in that one particular question.
Yeah, no, actually, I can just very straightforwardly answer that. Like, if we go back to our country, India, Pakistan, and all, there is no concept of physician burnout or healthcare provider burnout right now. People do not even believe that. So you know that very well, that it's like, oh, you're a doctor, how come you can get a flu? So,
it is very,
so
very
that's the
difficult
thing.
to get a sick leave in Pakistan,
Exactly,
I worked in
yeah.
Aga Khan for more than 2 years and didn't get any leave. 365,
Exactly.
like all the time on duty.
Exactly.
And
And
even
in
annual leave,
and
if you want to go for apply for annual leave, they will make you in trouble, If you ask for annual leave and you're going to fill the form, they go. They behave very badly.
Because overall,
They
in
don't take
general, in
annual
our
leave.
society, mental health is kind of a
Aga
taboo.
Khan is known for this. Aga Khan is known for this. They make you physical damage, I have back pain for so long, after working in Aga Khan.
Yeah, and
I'm still
I can
recovering.
I'm so sorry for that, what happened, but yes, I can understand what you're saying. So in our part, in this part of this, I would say emerging economies, there is no concept like that. Coming to UAE and Saudi Arabia, where I do have a work experience, so usually they give you a monetary compensation. They will still make you work without understanding that you're going through a mental exhaustion. They will keep on like, yeah, you can cash your vacations, you can cash your leaves, or maybe we'll give you 5% increase. Or if you work in Ramadan, whole 12-hour shift or something, you will get an extra bonus, extra salary by the end of the month. So this is something Faisal would agree with me. He is working in the same environment. He knows.
Interesting.
So,
Interesting.
which is something very wrong in UAE. The things are changing. They are focusing on this, and they are, starting to take care of it.
Okay. No, that's really helpful. Thank you very much for that perspective. Naseem, I think Anila Amreen has got something to say about her experience.
Someone is saying something.
I just wanted to share a comment from Dr. Imran Mushtaq, who is a child psychiatrist and also my appraiser for the past few years. A very, very nice guy. So I think his comment is that he is a child psychiatrist, and he's saying that the burnout also significantly affect psychiatrists also, and a reason for suicide in many cases. So very important point. Manila's question is, burnout had always been there. Thanks to COVID, there it's been highlighted more than ever. So yes, I think this is a comment. It's not a question. There's a question here. What's your take on patient satisfaction surveys in institutions every now and then? Do you think they make up for the psychological stress or just add to it?
All right, so that's two big topics coming together. So patient satisfaction, yes, you are right that sometimes it can be very, very demoralizing for us when we receive very negative feedback from our patients, despite of the fact that we have done our best to treat them and to provide them the best of the services. But yes, it will have psychological impact. But once again, look for help. Maybe you can reassure yourself by talking to your colleagues the decisions you took, because sometimes, especially in the private practice, the patients sometimes go unreasonably beyond like harsh comments and feedback. So in that case, it should not be impacting you psychologically, but seek help, get the reassurance about your decisions and the things that you have done. On the other side, if there is something which you feel like that, it's a positive critique, maybe there is something which I need to improve in my behavior, because we doctors are always in a hurry. I was thinking when I was discussing with Naseem that I was actually thinking to bring active listening as a skill for physicians, which I do train people in corporate sector, in call centers and all that. But as a physicians, we know that how important it is. So let's take it as something like, oh, okay, I am listening to my patients. Maybe they are giving me a feedback, a place where I need to improve. So look into it in a positive aspect, as a positive critique, I would say, not rather than like taking it as a negative impact. So patient satisfaction, yes, it can give you a good positive blow as well, and sometimes a negative as well. Totally agree. I hope I answered your question.
Thanks,
Yeah.
Varda. We have a question for Dr. Zubair from Anila Ambreen, who is a gynecologist. She's asking any advice on additional antenatal monitoring for fatty with family history of epilepsy, especially epileptic mothers, on polytherapy.
Good question. I have to admit, I don't know much about polytherapy, but a valid concern here. The genetic epilepsy, children should be screened early on, and some of pathologies like diffuse cortical dysplasias or Hemi-Meg and Sturge-Weber, some of them can be detected antenatally on their MRI scans, but usually prenatal imaging is primarily focused on dystrophism, either cranial or spinal, rather than these pathologies. But there is an opportunity, if the concern is high, these imaging can be performed like fetal MRI scans. Postnatally, if there is strong family history of epilepsy, there is a good reason that the children should be offered genetic testing to rule out genetic epilepsy. From treatment point of view, unfortunately, sadly, epilepsy surgery is not a treatment option if a patient is suffering from genetic epilepsy. Then they have to explore our other avenue, like anti-epileptic medications or dietary routes, ketogenic diet.
Zubair, question: the temporal lobe that you remove. So any weakness or any neurological deficit after that?
The only epilepsy operation which will cause post-op deficit is hemispherotomy. So the child has to agree. In fact, their parents need to agree on that the child will be hemiparetic. And to be honest, these children are hemiparetic to begin with. So if you have got an MCS stroke, that hemisphere is not working. Even on dominant side, if you develop Rasmussen encephalitis on dominant hemisphere and your speech is involved, children are very good in moving their functions to the other normal part of the brain. But hemispherotomy and TOP disconnection will lead to some sort of deficits post-op, not temporal lobe. After temporal lobectomy, we don't expect any weakness.
Thank you. Dr. Imran Aziz is making a comment saying, may I suggest you watch old PTV play Maya or Monsoon, part of our drama shown in 1989. Is that to for the Dr.
Can I come in?
Yeah, please do.
Yes, yes.
It's not our, it's or drama, or kuch or
Mazid, additional
or drama. ये अशफाक अहमद के ड्रामे थे. Basically, what I'm trying to say to you is कि mental health is a major problem. I will never deny that. But mental health is a bigger problem in people. अगर आपके घर में आपके खाने को रोटी नहीं मिलेगी ना, तो आप में मेंटल हेल्थ नहीं होगी. आप जैसे कहते हैं ना, टूटे हुए लात के साथ भी आप कमाने के लिए जाना पड़ेगा. जब आपके पास टाइम होगा ना और पैसा होगा ना, तो मेंटल हेल्थ ज्यादा इंपॉर्टेंट होगी. बिलीव मी, that is why it is less in the third world countries.
Basically,
Dr. Imran Aziz is a very senior consultant respiratory physician. He is the guy who trained me. He is my mentor. He is my senior. My first job was under him, and he is one of the most intelligent physicians I have ever worked with. And Dr. Aziz, thank you for joining today.
And actually, that's a very lovely thing that he has added over here. I was just talking about it, that yes, there is something which is known as Maslow's hierarchy, where if the basic needs of life are not fulfilled, of course, you cannot go and look for other things. But fortunately, most of us are having those basic needs, jaise ke khana, pehna, kapda, rehne ki jagah, sone ki jagah. We have all that. So of course, mental health is something which we need to focus. But of course, in our society, people are so focused in that, just to get all these basics in life, that they don't think that mental health is an issue. And once again, this is a very positive way. Actually, sometimes this is what I do as well, that if I'm feeling very low and I'm feeling that I'm not achieving anything which I was expecting, I sometimes go back to old movies or dramas or songs, which I once upon a time heard at a time when I was very happy. So it kind of takes me back to that mental, you can say, that positive vibe or feeling. Faisal looks very happy hearing this. I hope he's thinking which song he's going to listen to right now. So this is what I did last weekend. I was just sitting and listening to Junaid Jamshed old songs. Tum dur the to kya hua, tum mil gaye to kya hua. It kind of takes you to that Jawani ke din and khushiyon ke din. So hopes wale din. So one last thing, if Mansoor and Asim, would you allow me, if you allow me to that?
Go ahead. Yeah.
Actually, I am currently working on a research which is basically focused on implementation of robotics and emerging technologies in healthcare. So I'm in a phase of conducting interviews. So if anybody can connect me, any of your colleagues or even if you are working with that, so I will be just requiring 20 to 25 minutes to conduct some interviews to see that what was your experience when you started adopting the robotics. So that will be very kind if anyone can connect me to anyone or be part of those interviews. Confidentiality, and of course, everything will be done.
I've got some urology surgeons who actually work with robotics in urology, so I can definitely ask them, and then I can pass on the details. Thank you.
Thank you so much, host, and thank you so much, Dr. Zubair. It was a pleasure talking about brain.
Yeah. Dr. Zubair, anything else you would like to add before we finish the session?
I just want to thank everyone for attending this session, and Mansoor and Naeem, you are doing a great job. Naseem. So yeah, thanks for the opportunity.
Thank you very much. Inshallah, we'll call you back.
Thank you very much. Thank you. We'll see you all next month. We have 2 confirmed presenters, and we'll share the details in various other groups. So Mansoor, thank you very much for helping me.
Thank you very much.
Thank you, everyone. Stay positive, everyone. Bye-bye.
Bye-bye.